Hello, everybody. I am Steve Johnson, president of the Albert Ellis Institute, and welcome to REBT Works, where we just sit around and talk about everything related to REBT. And today, I've got an individual that I am really excited about because we're friends, but I haven't seen him in ages. And so not only am I recording this for you guys, I want to know what's going on with him. So, Cort, do you mind introducing yourself and then in good New England fashion, just jump into work and kind of tell us what you've been doing as a clinical social worker and psychotherapist over the last few years.
Okay. Yeah, well, my name is Cort Heine. I'm a clinician currently at the Institute of Living in Hartford, Connecticut. The last few years, really since I graduated from UConn as a social work major, I got my job here at the IOL and started at the inpatient hospital. Spent 2 years doing inpatient work with a variety of folks that are very acute and doing a lot of casework, but also leading groups and also some individual therapy when the patient was available and the situation warranted. Then the last 3 years, I transitioned to an intensive outpatient where I work with young adults who are undergoing an initial psychotic break. And so we work mostly in a schizophrenia family of illnesses, but we also get folks that may be suffering from other diagnoses that also had with it some psychotic symptoms. So that's what I've been doing the last 3 years now.
And in all of that free time, yes. It's good to catch up on that. I mean, Institute of Living is quite a major organization, well known outside of Connecticut. So you've lasted in there for quite a long time. That's fantastic. Cort, when you are doing therapy, and then I know you're dealing with individuals, with psychotic conditions, but also you've started a little private, at least. Yes. Provisionally in a private practice. I'm really curious about what models of therapy do you tend to gravitate toward?
Yeah, I should have mentioned that too. Probably about a year and a half ago, I started a private practice a couple of nights and on Saturdays. And that's gotten bigger and bigger since then. So I probably am up to now 14 or 15 clients on the side that I just see. And that's a variety of folks with different needs. I would say that because of yours and my mentoring relationship, that REBT was really one of my first modalities that I really learned well and felt like I had a firm footing. I don't think that school prepared me very well to do therapy, particularly social work school. It's a pretty broad education. You have to take kind of a general curriculum until you really hone in on, I went into a kind of a casework specialization, but I thought that would lead to more learning how to do one-on-one therapy. And there might've been one class that just gave you sort of every academic perspective on all the different types of therapy. So I got just a very small spoonful of family systems and object relations and just, you name it, but it wasn't anything that could have prepared me to do that professionally. So there was quite often there were times when I felt like I was faking it until I, could make it, where I had my REBT to fall back on. And I would say, honestly, I know I'm talking to you and there's a slight bias here. But I think inpatient, the thing that REBT did really well is it gives CBT very much a practical application, very much of a formulaic explanation. So instead of more broad thought distortions that may or may not apply to each individual, I liked I call it an equation that you can walk folks through that's very practical, very focused, easy to understand, especially for someone even in an acute mental illness break or situation. I could walk them through, some of the ways that their thoughts were affecting their emotions. And where I think traditional or the backside of things might leave that more to question. I felt like REBT we just make the assumption that there's a thought there, there's a should there. Let's find it and help you see, at least initially, how this is affecting you in a really unpleasant way. And so it's been interesting how that really was a good fit for my inpatient situations. And then since I've come here to work with those that are suffering from psychosis, you know, the CBT for psychosis track, I think, lends itself more to the Ellis side than the Beck side of things. And so, again, it just offers folks who may be struggling to some extent, if not cognitively, they're struggling from a linear thinking standpoint. It just gives them a really easy framework to sort of understand, as opposed to something that's very much more broad, I guess, if that's the right word. So I found it really, really helpful, to be frank.
Yeah, Cort, a couple of things came up there. One, there'll be some professors out there who are listening to it. And I know as a professor, I struggle with this. Should we give them a broad smorgasbord approach, or should we zero in on a model or two and go into depth on that and then talk about differences with other models in the hope that they'll make a selection and eventually go into continuing education units, right? Maybe to there, but it sounds as though you had some concerns about a more open smorgasbord approach.
For sure. Yeah, I think that had I not had, I'm going to lose the terminology. I got my first certificate at the Ellis Institute, and then the advanced, I think. The primary and the advanced, do I have that right? If I hadn't had those, I couldn't have gone into private practice. I just would not have had the background. Even now, I have an outpatient or a private practice supervisor that I lean on pretty heavily. But I feel like from a cognitive CBT intervention standpoint, I feel very confident intervening from that side of things. You know, I do think that as a newer clinician, there's still the behavioral interventions that I'm working on developing a toolbox of things, maybe from an exposure standpoint, related specifically to anxiety, that I'm still, I think, building some confidence. But particularly when it comes to those folks that are depressed, I just find that knowing REBT as well as I do was a godsend. It was certainly a professional vault to a place I wouldn't have been ready to be. And had I just gone to UConn, you know, really everything I would have learned, I've learned just on the job. And that's more from experience even than from teaching. You just catch it as opposed to it being taught to you. So I think having a class in school where you might learn a specific therapy concept in depth, sort of the way I was able to under you, and then allowing you to maybe branch out, like you said, with CEUs after that to learn some other, you know, other types of therapy that might be helpful, and certainly would have given, I think it would give folks a stronger leg to stand on when they begin.
And Cort, that second point that I wanted to follow up with you on is something that may surprise some of our viewers to think that a second wave model like REBT or CBT or even third wave ACT or DBT could actually help someone who is experiencing psychosis, maybe a shock to them, because you're going, wait a minute, wouldn't you have to have kind of an intact cognitive apparatus? You know, many people think of schizophrenia as a thought disorder, but saying that you find at least a REBT model that you've used to be helpful with individuals who are experiencing psychosis?
100%. I mean, obviously with someone that's that acutely ill, there's a combination of medications that has to happen first to get them to a place where the learning and the therapy can be received. But I think that's put it at a really good, it's at a really good place in my position now. We're an intensive outpatient program. So we meet 3 days a week, 4 hours a day with these individuals. And I would say at least one group a week is specifically a CBT group. I mean, that's what they call it here. They don't know oftentimes that I'm teaching them REBT. I will tell them, I'll be honest with them when I'm a little bit more Ellis slanted, but the way that I explain it is much more the ABCD model than the thought distortion model. And they really take to it. I think it helps them understand that even when the activating event is internal, it helps them to understand that the thoughts that they're having about that can be helped, can be, for lack of a better word, can be reassured, right? We can help comfort them, or they can even help comfort themselves through some restructuring of those thoughts that they're having about the activating event, even if that's an internal event.
Yeah, I really like that, because so often I think even within REBT, we treat the activating event, critical activating event, whatever, as, you know, from the external environment, but very often it is some internal event that can be what's activating any emotions or whatever, right?
Yeah, absolutely.
Amazing. That's amazing. Do you mind, I don't know if you remember a story, I think it was shortly after you got to, where you are now, that you were in a room with a psychiatrist and maybe psychologist or whomever, and they were working with a client and they asked you to step in. You were using that ABC model and they ended up being a bit amazed. Do you know what story I'm talking about?
I don't know that I can place it. There's been a lot of stories since then, but I think one of the things that I appreciated working inpatient here is I got the chance to work with a few doctors, and one of the doctors in particular, she and I would sort of tag team therapy sessions while we were inpatient with the folks that were able to receive that. And I think at some point, yeah, there were often times where she would want me to just pull out the ABCD and either do it on a slice of paper or on a whiteboard, and just help them understand that combination. And I would say this, I know this sounds like a commercial now, but Dr. Ellis is on YouTube. I feel like it's free reign if it's on YouTube to share the story, but his story of that, he kind of the example he uses of the connection between our thoughts and our emotions, when he talks about the subway ride and the person getting elbowed or getting the cane in the ribs, and the emotion you feel before you turn to see what's happening, oftentimes is something like anger, and then you turn and you see it's the elderly blind man that just lost his balance, and how immediately your emotion is, if not erased, it's replaced by something like pity or some shame or guilt that you were going to elbow this poor blind man in the ribs. I would say I've used that story 100 times since I've worked here at the IOL, and I think that combined with just the ABCD model, it just helps folks that have no otherwise experience with CBT. It helps them to understand the basics much better than any other way that I've been able to explain it. So I think that's what she was most impressed by, was my ability to sort of summarize something that can be kind of complex into something that folks that are acutely ill can appreciate and understand.
Good deal. So you're ready to take the plunge?
I'm ready to take the plunge.
Scary world of private practice. As you're doing it, of course, you've already eased into it.
Mm-hmm.
As you're making that shift, have you noticing any emotions coming up in you, Cort? I don't want to turn this into a section.
We could.
And you know, when they come up, do you wish that there had been something that you learned earlier that would have been helpful? Are you you know what I mean? Are there things that you wish you had been taught before you're, you know, kind of, you are the business, right? And it's on you. Yep.
Yeah, I think again, it's going to sound like I'm just kissing up, but I think that getting to work under you for several years and having that mentorship was really helpful from a clinical standpoint. I mean, there are just some things that you and I talked about and some things that I learned early on and just conversationally that I wouldn't have gotten at school. I now am privileged to be working with a supervisor who's taught me a lot of the sort of the nuts and bolts of a business side of private practice, just some of the best practices that I would not have, I don't think, intuitively understood, just how to schedule clients. If someone wants to meet with you every other week, you hold that place as an every other week time, and you look for someone else that's wanting to see you every other week, and you can kind of slide them into that puzzle piece. And then working with insurance companies is just a whole mountain to climb on its own. So I think in that sense, those are things that I wish I would have learned earlier, because it's probably, I've been at this now almost a year and a half, just kind of working my way towards private practice alone. But I would just say, going back again to what we talked about before, I wish I would have known more practically how to be a clinical therapist. You know, I think, again, at least in social work, the education is so broad. You know, I took classes with folks that are going to work at the UN, and that's not to diminish that. It's just so drastically different than sitting one-on-one with a client and working through depression or anxiety or something like that. And I think I would have been, because that's what I knew I wanted to do, I would have benefited from having a CBT class, an REBT class, and even if it's just to make me confident that I don't know as much as I think I don't know, if that makes sense, that there's just this feeling that there's more that I should know at this point. And having a class or having something exhaustively educational helps just reassure you that you probably do know more than you think you do. But because it wasn't formalized and it's just being caught along the way, it always feels like, you know, maybe there is something else that I should have been more advanced at. So even from a confidence standpoint, I think it'd be great to have that more specific educational background when it comes to sitting in a room and executing one-on-one therapy.
So you've talked about having a couple of mentors.
Yeah.
In addition to your educations that kind of fill in the gaps. So is that something that you would recommend to people who are about to graduate then? Get a hold of mentors.
Yeah, 100%. And I don't want to do any, I don't want to forget to mention some of the mentors I had when I did my internships.
Yeah.
Again, social work being so broad, UConn wanted to send me on some internships that were just not what I needed, what I was looking for. And I really had to argue and fight and fuss to get, I ended up at Charlotte Hungerford outpatient clinic at the hospital in Torrington, Connecticut. And that was invaluable, to spend whatever it was, 9 months seeing clients one-on-one, and then having someone at the end of the week to have supervision and talk about my client list with and help them go through some different therapeutic possibilities and ideas from a diagnostic standpoint to an intervention standpoint. I mean, that was, I guess I shouldn't sell UConn short, because that was invaluable as well, but I really had to fight for it. I had to kind of claw and scratch to find that. It was not natural or wouldn't have come easy. And so I think for folks that are in school right now, my advice would be, don't be afraid to fight a little bit, to argue, to, you know, it's your education, it's your dollar. And I was probably a huge pain in the butt to the folks in the office at UConn, but I benefited from it greatly and finally got to the place where I really felt like I needed as far as my career growth went.
Cort, right now I'm directing an MA in addictions counseling program. And I did that because I was totally surprised when I was in private practice about the huge number of addictions out there, not only substance use, but also process or behavioral addictions. And I felt ill prepared for that, given my education. I was wondering whether education has changed in that area. Do you feel like that you were prepared to handle, I mean, you were at Charlotte Hungerford, so I'm imagining you've got a good number of addiction cases coming in there.
Yeah, I got some co-occurring, some dual cases. Yeah. You know, I think the situations where I felt more helpful was when, I don't know if you would classify it specifically as a primary addiction, or if it was just self-medicated overuse related to some other mood disorder. Yeah. But sort of traditional substance abuse treatment, I didn't get as much education. And right now, if someone wanted to send me someone that was a little, you know, even someone that might have co-occurring alcohol or drugs and a mood disorder, I'd feel a little underprepared, to be honest. I would feel like I didn't get as much education as I needed to help folks, like you said, and there's so many of them out there that are suffering from both at the same time.
Well, I can't say I'm glad to hear that, but I am creating a course on co-occurring disorders in our program. So I just felt, I knew I needed that and I didn't get it. So I had to do it through an education kind of way. Yeah. Well, all the best as you make this plunge. You look like you're prepared. Any last words you want to give somebody who's trying, they've just graduated? Would you tell them, yeah, it's a good idea to go with some kind of institute or organization? Or would you say, forget that, launch into the private practice?
No, I would say 100% don't immediately launch into the private practice. That would be my advice. I think that my time inpatient at the IOL was invaluable. It's really, really hard. It chewed me up a little bit, but I spent 2 full years as an inpatient clinician, and I feel like I just about saw it all. Running the gamut from different disorders, different diagnoses, different life situations. You get a ton of experience sort of learning about our flawed mental health system in America, from the insurance company to the lack of options for folks when they come out of the hospital, whether it's folks that are struggling with homelessness or substance abuse or family systems issues. I felt like in 2 years I learned 7 to 10 years worth of experience. So especially in my case, I was a second career, shifting from one career into being a therapist. And so I thought it was invaluable to have those 2 years to really catch up. And I noticed in these last 3 years, even here at the Institute, I think whether it's a diagnostic standpoint or just understanding meds, things that I would not have otherwise had an exposure to or an education about, I'm way ahead of where some of my colleagues might be, who we might have spent the same amount of time in our careers, but just that inpatient time, it's like education on steroids, I guess. It just, you learn a lot. So I think as hard as it might be, it can be a really helpful experience for someone coming right out of school.
Well, Cort, I want to thank you so much. And to those who are out there watching this, hope that you will stay tuned for the next episode of REBT Works. Have a great day.